Hi, I'm Jenn Craig. I'm a speech pathologist at the Vanderbilt Voice Center, and I work a lot with patients with head and neck cancer. Patients with head and neck cancer oftentimes have something called dysphasia. Dysphasia is a fancy way of saying swallowing trouble. Swallowing trouble can be anything from food and liquid getting stuck on the way down, food and liquid going down the wrong pipe, or food and liquid coming out the wrong pipe. Dysphasia can be very, very dangerous. If food and liquid go down the wrong pipe towards the lungs, oftentimes it's uncomfortable and it can make a patient cough very heavily and very frequently. If it does go down the wrong pipe, it can also give a patient pneumonia. Especially in our head and neck cancer population, when immune systems are already kind of depressed and patients are weak, pneumonia can be very, very dangerous. So speech pathologists are called in to help manage dysphagia. Speech pathologists have a few different ways of diagnosing dysphagia or difficulty swallowing. One of those ways is called a modified barium swallow study or a video fluoroscopic swallow study, and that's the video you'll see running here. What we do is we give patients different textures of foods, different consistencies, and that is either a thin liquid like water, a nectar thick liquid, which is just a little bit thicker, a honey thick liquid, which is about the consistency of honey, purees, and solid foods, or combinations thereof. We mix those with barium, which is a radio-opaque material that lets us watch that food and liquid go down under an X-ray. Then we can see both functionally and mechanically what's going on during the swallow itself. Oftentimes we can make recommendations about any diet modifications that need to happen or any compensatory strategies that the patient might benefit from. Head and neck cancer patients oftentimes also have something called dysphonia. Dysphonia is a fancy way of saying hoarseness or roughness, raspiness, or an altered quality of the voice that's different from what the patient usually hears out of themselves. Speech pathologists can help patients undergo voice therapy. In some conditions, patients also undergo radiation for cancer of the vocal cords. Speech pathologists have tools to help diagnose dysphonia, including endoscopy. In endoscopy, we can actually look at the vocal cords and get an image similar to what you see here. In this picture, I can actually see all around the voice box the vocal cords themselves, the base of the tongue, and other structures and mobility, and determine whether or not there are any impairments in that sense. Oftentimes patients with head and neck cancer can have mobility impairments, and the vocal cords don't vibrate quite like we would expect them to. The vocal cords themselves open and close when we talk, when we breathe, and when we swallow. When we're breathing, the vocal cords sit in the shape of a V right on top of the airway. When they're working properly, they're wide open. When we go to speak, the vocal cords swing together, close, and vibrate, vibrating air to allow that vibration to come out as our voice. In patients with head and neck cancer, especially those that have undergone radiation treatment, the vocal folds may not swing open and closed as readily. That can oftentimes cause breathing difficulty. If the vocal cords are swinging together or they are stuck in a median position, that will oftentimes block the airway, not allowing air to pass readily down towards the lungs. Some types of head and neck cancer impact the voice box directly. They impact swallowing, voice production, and breathing. In some patients with head and neck cancer, the voice box is no longer functional, and they also have trouble safely swallowing, breathing, and oftentimes they have difficulty with their voice as well. If this is the case, sometimes these patients must undergo what's called a laryngectomy, and that's a removal of the entire voice box itself. Typically, the food pipe and the windpipe share a common pathway towards the mouth. So when we eat and we drink, our windpipe closes off and it allows food and liquid to bypass our lungs and go down towards our stomach. When we're breathing, our food pipe stays closed and it allows air to go through our nose and our mouth and go down towards our lungs. In patients that have undergone a laryngectomy, the food pipe and the windpipe are no longer connected. The windpipe is turned outwards to form something called a stoma. The food pipe is then reconstructed so that somebody can eat and drink without the risk of something going down towards their lungs. Just because a person has had a laryngectomy doesn't mean that they can no longer communicate. There are several different options for communication in a laryngectomy patient. One of those options is called an electrolarynx. It's the buzzy thing that looks like this. A patient places it against their neck, presses the button to activate the device, and then speaks. For example,
1, 2, 3, 4, 5.
Another communication option for a laryngectomy patient is called a TEP, or a tracheoesophageal prosthesis. A surgeon will put a puncture in the common wall between the esophagus and the trachea. A speaking valve is placed, and the laryngectomy patient will reach up, cover their stoma, shunting air back through the speaking valve, vibrating the tissue in the esophagus, allowing the patient to get speech. One of the hardest, but one of my favorite parts of my job as a speech pathologist is the counseling aspect for head and neck cancer patients, and specifically our laryngectomy patients. We sit down and we talk about what can you expect from surgery, both the anatomical changes, the physiologic changes, but also what do you do after surgery? How do you get back to your new normal? How do you begin to approach working again? What are social interactions like? But the bigger part is oftentimes we get to introduce some of our patients who have already been through the surgery and have been through all the hard parts and the hard steps and are making their new way of life, and they're doing great. It's fun to watch those patients talk to patients that are about to have the surgery. What's amazing to me is the community that's formed between our head and neck cancer patients and how much they lift each other up and encourage each other. It's very humbling, and it's absolutely one of my favorite parts of my job.